Hello, this is Miss Dennison. I am, we're going to go over Chapter 13, the labor and birth process. So there's many different factors that influence the onset of labor. There's not really just one cause. Basically, the cascade theory talks about how the uterine stretches because the fetus and the amniotic fluid continues to get bigger and more. Also, progesterone will withdraw, and that is leading to estrogen dominance. Also, increased oxytocin sensitivity and increased release of prostaglandins. Prostaglandin is a hormone-like substance that participates in many functions such as contraction and relaxation of smooth muscle, dilation and constriction of blood vessels, control of blood pressure, and modulation of inflammation. You will see that in infections, you will see that in inflammation, those increase in prostaglandins. The placenta also produces corticotropin releasing hormone, also called CRH. This is thought to regulate the duration of pregnancy. So, for example, if a woman is experiencing stress, particularly in the first trimester, the placenta increases the production of CHR. The CHR suppresses the mother's immune system, preventing the mother's body from attacking the fetus. Later in the pregnancy, it improves the blood flow between the placenta and the fetus. So premonitory signs of labor. So the cervix will change. It will get soft, possibly will start to dilate. These cervical collagen fibers will absorb water, and that makes it softer and more flexible. This allows effacement and dilation. So the cervix actually starts out as an elongated tube that ultimately becomes short and thin. Think about your head going through a turtleneck shirt. That's kind of how effacement and dilation go. Also lightening, that's when the fetus will descend into the pelvic, the pelvis. The uterus will lower. That makes breathing so much easier on mom. She will also have less gastric reflux, increased pressure in her lower abdomen, leg cramps, edema, low back discomfort because the baby has lowered down. Also increased vaginal discharge, frequent urination because that baby is laying now on a bladder. So then there's also something called nesting, which is an increase in energy level 24 to 48 hours before labor onset. That progesterone is decreasing, which increases epinephrine. So mama starts cleaning, cooking, preparing the nursery, getting everything ready, getting her bag ready for the hospital, basically getting everything ready for the baby to come. Just a big burst of energy. The bloody show is usually at onset of labor or before. That mucus plug that fills the cervical opening is expelled. So then ruptured cervical capillaries mixed with mucus will lead to a pink tinged discharge known as the bloody show, also called the mucus plug. Braxton Hicks contractions, these are not true labor. These are contractions, they're more frequent. They're tightening or pulling at the top of the uterus and the abdomen and the groin, and they are irregular. They will decrease with walking, voiding, eating, increased fluid intake, or changing position. So true labor contractions start in the lower back and walking will encourage them. Braxton Hicks, if you walk, they decrease. If you drink water, they decrease. If you lay on your left side, they decrease. If they're lasting 30 seconds to 2 minutes and occur 4 to 6 times an hour, this may indicate preterm labor, so she needs to holler at the doctor. Spontaneous rupture of membranes. So pre-labor or preterm rupture of membranes is usually prior to the onset of labor. 8 to 10% of term pregnancies go into labor within 24 hours. The amniotic fluid replenishes itself. Once that rupture of membranes happens, you want that baby to be born within 24 hours because you have an increase in infection, also increased risk of cord prolapse if the baby is not engaged and it's just floating around. A lot of people, especially when you watch television, they say, oh, the water breaks, run to the hospital. You don't necessarily have to go to the hospital right then, but definitely call your provider and let them know exactly what time. That way they can get everything ready. So look at the table in your book that has the differences between the true and false labor. You will need to know the difference between these. With false labor, again, they are irregular contractions, but the cervix is not really affected as compared to true labor. So these are the warm-ups, getting everything ready, engaging the head. These are usually painless, feels like a balling up feeling, and the body is basically just practicing. With true labor, your contractions are regular. They will increase in frequency, duration, and intensity. These will bring about cervical dilation and effacement. They will usually last between 30 to 90 seconds. Go to the hospital if it is 5 minutes apart for an hour. Again, walking makes these worse. So it is a very important nursing skill to have to distinguish between true and false labor. Again, the things that you let mom know: drink some water, walk or lay on left side, wait, and with first pregnancies, the cervix can take up to 20 hours to dilate completely. If the contractions diminish in intensity after drinking or walking, stay home. Don't go to the hospital. So these are critical factors that affect the process of labor and birth, which we will discuss more in depth. It's the passageway, passenger powers, position, and psychological response. Also, 5 additional factors per your book that affects the labor process. So philosophy, partners, patients, patient preparation, and pain control. So the passageway, think of it as the car or the birth canal, which holds the passengers, which are the fetus and the placenta. It has to be able to allow the baby to come through. So if you look in your book, page 441, it shows you the different views of the bony pelvis. So imagine that baby's head is going through that hole. So the linea terminalis, it's the line, it's just the division between the false and the true pelvis. The true pelvis is below that line. So the inlet, it's water sideways, then front to back. The mid pelvis is the curved space with the ischial spines. This is the very snug place which compresses the infant's chest, causing the fluid and mucus in the lungs to be expelled. The outlet is where the ischial tuberosities are wider from front to back. Now the false pelvis is the upper part, so above that linea terminalis, and it's the upper flared parts of two iliac bones and concavities. So when these things are measured, okay, the diagonal conjugate has to be 11.5 centimeters or more, and the true conjugate has to measure 10 centimeters or more, and that tells the provider that the pelvis is actually large enough for a vaginal birth. If it is not that big or more than likely that baby is going to be a C-section baby. So these are the different pelvic shapes. The gynecoid is the most favorable for a vaginal delivery. It basically looks like a pumpkin. The inlet is round and the outlet is roomy, as you can see from that view. The anthropoid is that the inlet is oval and the sacrum is long, and this is the second most favorable. So gynecoid and anthropoid were good. Android is the male-shaped pelvis. It's heart-shaped. Basically, all the segments are reduced in the planes, so the descent of the occiput or the head is going to be slow. Also, it's going to have a hard time doing all the rotations that it's supposed to. It's kind of alien-shaped, I guess, and these usually end in a C-section. So the platyploid, it's not favorable. It's a flat shape. It's like the beak of a platypus. It is the least common. It widens at the pelvic outlet, but the fetus has a difficult time descending through that mid-pelvis. So unless that fetal head can pass through the inlet, it usually leads to a C-section. So the cervix, and you can see these pictures, basically thins through effacement to allow that presenting part to descend into the vagina. The pelvic floor muscles help the fetus rotate as it passes through the birth canal. And the soft tissues of the vagina will expand to accommodate the fetus during birth. So all those things are the passageway. So this is the passenger. This is basically all the things. The skull, how the baby's face is positioned, which way that they're lying, how they are presenting in their position, which station is that presenting part in, and is the fetus engaged. So the skull is the largest and least compressible structure. The sutures, they allow for overlapping and changes in the shape, the molding of the head. It also helps to identify the position of the head when you do a vaginal exam. The fontanelles are intersections of the sutures. They also help to identify the position. And the different diameters are the occipitofrontal, occipitomental, suboccipitobregmatic, and biparietal. So the bones in the face are actually fused and fixed. They are immovable. Those bones cannot move. But these gaps in the skull are soft and pliable. After birth, these sutures will close as the bones grow and the brain reaches its full growth. Fluid or blood can collect in the scalp, but usually will go away on its own. The soft spot, or the interior fontanelle, remains open for 12 to 18 months after birth. So that's why you always want to be very, very careful with that head, because that soft spot does not close for up to 18 months. So these are the diameters of that fetal skull. Very important, the suboccipitopregmatic. is usually approximately 9.5 centimeters at birth. That is the smallest anteroposterior diameter of that skull. And then the biparietal is the largest transverse diameter. And the cephalic presentation, which is the head first, occurs in 95% of all term births. We want the cephalic presentation. We want that head first. So this is just a picture of those sutures, the diameters. It just kind of gives you an idea of what they look like. And another picture. Now, mom and dad will probably freak out about the distortion of that newborn's head, because sometimes they look like a cone head once that head gets finally through that vaginal canal and it's shaped and all the things. Just assure them that that is only temporary, because you will definitely need to reduce their anxiety. Cranial bones at birth are thin, weak, easily compressible. They're interconnected only by those membranes, which allows them to overlap under pressure and change shape to conform to that maternal pelvis. That's called molding. Caput succedaneum is a collection of fluid in the scalp. The swelling will cross the suture lines, but it disappears within 3 to 4 days. Now, a cephalohematoma is blood collection beneath the scalp, and it's generally reabsorbed over the next 6 to 8 weeks. So the fetal attitude is basically the relationship of the body parts to another. Either they're flexed or they're extended. So flexion is basically flexed extremities, and fetal extension is extended extremities. That fetal attitude is the relationship, I'm sorry, so basically that's the flexion or extension. This is basically the presentation with complete flexion, moderate flexion, poor flexion. This is just the picture that you can kind of see. So the vertex presentation is the head first, okay, cephalic. The military presentation, you can kind of see how that chin is, right? So you want that baby to be flexed. You want it to be just wrapped up in each other with that head up against the chest. But with military presentation and brow presentation and face presentation, it's very, very hard for that baby to get through that maternal pelvis and do all the things that it's supposed to do, turning, descending, all the things, and rotating. So the fetal lie, this is pretty easy, is the relationship of mom's spine to the fetus's spine, okay? So the longitudinal lie, that's up and down, that's what you want. The transverse lie is sideways. You don't want that. As you can see, it would be extremely hard for a baby to get through that maternal pelvis if it's in transverse. The oblique lie is at an angle to the spine. And a transverse or oblique lie cannot be delivered vaginally. So you want that longitudinal lie. Fetal presentation, so the part of the fetus that enters the pelvic inlet first. Okay, so you want it to be cephalic or vertex. Okay, again, I gave you the pictures of the military brow and the face. Also, there is a breech presentation, and that is where the head is up. So there's different there's different breeches, types of breeches. So the frank breech is 50 to 70% of breech. The butt is first with the legs extended towards the face. There is a full or complete breech. This is cross-legged above the cervix. The footling or incomplete breech, that's one or both legs are presenting. And only a frank breech can result in a vaginal birth. All the other ones have to be C-section. Now, a shoulder presentation is also usually a C-section that is necessary. You get into problems with shoulder dystocia and all the things. Fetal position. Now, this is going to be extremely confusing. So I put a beautiful video on here that will help you tremendously. You can watch that on your own. So there is a 3-letter abbreviation to identify this fetal position. And so occiput is the cephalic or head first. Okay. The occipital bone is the bone at the back of the head. The sacrum, the scapula is an A. That's the shoulder presentation. The chin is mentum. That goes with the M. That's the face presentation, which we don't want to see. Then the buttocks, which is the breech. That's the S. That's for sacrum. And so the first letter is either R or L, and that is the presenting part is on the left or the right side of the maternal pelvis. So it could be the occipital bone, it could be the mentum, it could be the sacrum, and I'll show you a picture in just a few. The second letter is the OMSA, whichever one that is. So what part of the baby is going to be presented to the world first? Is it going to be the vertex presentation? Is it the head first? Is it the chin first? Is it the sacrum first? The scapula? And then the last letter is anterior, posterior, or transverse. So is the baby's back towards the mother's belly? That's anterior. Is the baby's back towards the mother's spine? That's posterior. Or is it sideways? Transverse. So the best position would be LOA. Okay, second best is ROA. So left occipital anterior, or right occipital anterior. You don't want it to be P. That last letter, you don't want it to be P because it causes a lot of pain, a lot of complications, and that's the sunny side up delivery that you don't want. This is just a picture of the occiput, vertex, sinciput, the mentum. So this is a really cool picture that kind of explains those letters, and you can see how these different positions can cause problems going through that maternal pelvis. So the fetal station, the fetus's presenting part in relation to those ischial spines. So if you see these right here, that's your ischial spines. That is the smallest diameter that baby has to go through, okay? So it's basically letting us know how far that fetus is progressed down that birth canal. So the presenting part, it is at 0 station once that head is engaged. Now, there's a word called floating that is used. That's when the baby is not engaged. So clearly, as you see, the baby just kind of floats around. And that presenting part is freely movable about that pelvic inlet. So the best way to kind of remember this, the plus or positive is good news. That means that the baby is coming. So remember this, plus 4 is on the floor. That baby is out, okay? The negative or the minus number is bad news. The baby is not here yet. Here is another picture of that. And another picture of that. This is actually probably the best picture. I like this picture better. So fetal engagement signifies the entrance of the largest diameter of the fetal presenting part into the smallest diameter, again, the ischial spines. This typically occurs in primigravidas 2 weeks before term, and multiparas may experience engagement several weeks before the onset of labor, or not until labor begins. So this is kind of really cool because our bodies are so amazing, and how these babies are born, their bodies and our bodies they just work together. So there's specific movements of labor that the baby and also the pelvic floor muscles, the vagina, the cervical dilation, those uterine contractions, all these things work together to produce these cardinal movements of labor, okay? So the first one is engagement, the greatest transverse diameter of the head, okay? It's usually at 0 station. So that head enters the pelvis with a sagittal suture aligned in the transverse diameter. Then there's a descent. That's the downward movement of the fetal head, and until it is within the pelvic inlet. This basically occurs intermittently with contractions from the pressure from that amniotic fluid, the pressure of the fundus on the buttocks or head, the contractions of abdominal muscles. This will occur throughout labor, and it ends with birth. So flexion occurs as that head meets resistance from the cervix, the walls of the pelvis, and the pelvic floor. That chin, hopefully, is brought into contact with the fetal thorax, so its chest, and the presenting diameter changed from occipitofrontal to suboccipitobregmatic, which is the smallest diameter presenting in the pelvic dimensions. Then you have the internal rotation. So as that head descends, the lower portion of the head, usually the occiput, the back of that head, meets resistance from one side of the pelvic floor. Basically, this results in that head rotating about 45 degrees, bringing the anteroposterior diameter of the head in line with the anteroposterior diameter of the pelvis. Okay, so that it aligns the the long axis of the fetus head to the long axis of the maternal pelvis. Now extension, with the descension, with the full flexion of the head, basically that resistance from the pelvic floor causes that fetal head to extend so that it can pass underneath the pubic arch. That extension occurs after that internal rotation is complete. That head emerges through the symphysis pubis along with the shoulders. So at this point, the anterior fontanelle, the brow, the nose, the mouth, and chin are born successfully. So that head's out. So then external rotation, also called restitution, is after that head is totally born, free of resistance, it untwists, causing that occiput or the back of the head to again move about 45 degrees back to its original left or right position. The sagittal suture has now resumed its normal relationship to the transverse diameter in the shoulders. That external rotation of the fetal head allows the shoulders to rotate internally to fit that maternal pelvis. So we're getting the shoulders out. Then expulsion, the rest of the body comes out more smoothly after the birth of that big old head and the shoulders. So the way that you can remember these cardinal movements of labor in order, it's Edfieere. So every darn fool in Egypt eats raw eggs. So those are the cardinal movements of labor. There's two really cool videos that I put on there for you guys to watch. It just kind of shows you how the baby does. It's amazing. It's amazing. So apparently my thumb's got in the way. But the next slide is called powers. Okay. So this basically includes those uterine contractions, those intra-abdominal pressure from mom bearing down. So these are really important. Okay. You got to have these powers to get those that baby out. So basically they make the baby appear. These contractions are used to thin or efface and dilate the cervix while pushing the fetus to be expelled. So in effacement, it is calibrated in percentage. That just tells you how thin that cervix is. So 0% is 2 centimeters effaced, 50% is 1 centimeter effaced or thinned, and 100% is 0 centimeters effaced. Now, dilation is basically when the cervical os starts to open. So when it is totally closed, it is considered 0 centimeters dilated. When it is half open, it's about 5 centimeters dilated. And when it is fully open, it is 10 centimeters dilated. So when that cervix is fully dilated, it is no longer palpable on vaginal exam. So with those contractions, mild contractions are usually 30 seconds every 5 to 7 minutes. That's how you would document those. And as labor progresses, 60 seconds every 2 to 3 minutes. Each contraction has 3 phases. That's your increment, or the buildup, the acme, or the peak or highest intensity, and then the decrement, which is the descent or relaxation, which we will look at later. So now this one, the maternal position. So in the past, and you'll see with different cultures, there's a whole lot of different positions that you can be in to labor. So most of the time, and it's easier for us when mom is laying on her back, but it's not healthy. You want that mom to move around, okay? So if she's sitting upright, or she's standing, or she's walking, that gravity will assist in the descent, and there's less risk of compressing that maternal aorta. You'll notice, especially when you go to clinicals, you'll see mom in the bed laying on her side, because when that baby is mashed up against that aorta, her blood pressure drops, her heart rate excels like you, so it's best for her to lay on one side or the other. Your job is to encourage mom to take any position she wants. She wants to squat. She wants to get on a peanut ball. She wants to get on the back of the couch and whatever. You let her do whatever. That squatting, walking, it will assist that mom in opening the pelvic joints, and it makes the passage easier. So being able to do these things will actually decrease your need for C-sections. State of mind is critical for a positive outcome for mom and her family. some of the factors that influence the positive birth experience, giving clear information on procedures. When you check her, make sure she knows, hey, you're at 2 centimeters right now. Hey, you're 10% effaced right now. Also support, not being alone. I've literally seen a lot of women have their babies by themselves, and it's pitiful. Like, I can't imagine being by myself. But we don't know all the things that mom is going through, if she has any family, if anybody even knows. Maybe her family doesn't know. So support is a huge thing that will influence positive outcomes. Sense of mastery, self-confidence. Encourage mom the whole time. You got this. You can do this. I promise you. This is your body can handle this. Also, her trust in the staff caring for her. She has to be able to trust that you're doing everything for her that helps her with her pain, that helps her to understand better what's going on. If she cannot speak English, get an interpreter. So philosophy is huge. So some people have different feelings related to birthing plans. Actually, I said I wanted a C-section, and that was it. That's what I wanted. I did not want to have a vaginal birth. I just wanted to have a C-section, and that's what I did. And that was my birthing plan, and I don't feel bad for it. I don't have any regrets. And some people do, and some people won't. They don't want any drugs. They don't want anybody there, or they want everybody there. But respect that philosophy. Also, partners, they empower women within the birthing environment, such as a doula, the midwife, whatever, the spouse. The doulas are basically mothering the mother. They're caregivers. They delay interventions. They try to. Trying to allow mom to give birth naturally without having to go to a C-section. These are really great people. It's a really cool concept. So what is right for this woman? Make sure, keep her discomfort manageable while minimizing the risk to the fetus. Encourage maternal-infant bonding, breastfeeding, relaxation, preparing her mentally, decreasing anxiety and fear, and all those things. So there's a lot of things psychological that you need to do to encourage mom. So mom, while she is in labor, she will have an increased heart rate, usually about 10 to 20 beats per minute. She'll have an increased cardiac output due to all that blood. Blood pressure will increase up to 35 millimeters of mercury during those contractions. That's in all labor stages, so that's normal. Also, her respiratory rate will increase, and her oxygen consumption will increase. She needs more oxygen. There may be a slight temperature elevation because the increase in her basal metabolic rate, muscle aches and cramps, increased white blood cell count. It usually increases to 25 to 30,000. Also, decreased gastric motility. All of her blood and her energy is going towards those contractions, so they're going to have decreased gastric motility and food absorption, so you don't want to feed her right now. Also, decreased gastric emptying and gastric pH, which can increase the risk of vomiting with an increase in aspiration, heartburn, all the things, and also a decrease in blood glucose levels. The baby may have periodic fetal heart rate accelerations and slight decelerations. These are related to fetal movement, fundal pressure, and uterine contractions. Possibly a decrease in circulation and perfusion due to those contractions mashing on them. Also an increase in arterial carbon dioxide pressure, decrease in fetal breathing movements, decrease in that fetal oxygen pressure. So there's stages of labor. So in the first stage, the pain is basically due from cervical dilation and distension of the uterus and cervix. So it begins with the onset of contraction, so that's the true labor, and it ends when the cervix is completely dilated at 10 centimeters. It's the longest of the stages, and it's divided into two different phases. So the latent phase begins with the regular or irregular contractions, and it ends when 3 centimeters are dilated. This usually lasts about 6 to 8 hours. The cervix is effacing and dilating, but not much descent in moms that have never had a baby before. They may have scant brownish to light pink bloody show. Usually they're having mild contractions, and then they progress to moderate contractions. Contractions are usually every 5 to 30 minutes, 30 to 45 seconds in duration. Usually mom feels like she is able to cope with these contractions. She may be anxious, but she's okay at this time. Usually she's talkative and smiling. She's excited, able to follow directions. All the things are happening. She's all excited. This baby's coming. Then we get to the active phase. That's from 4 to 7 centimeters. That's the second longest phase, which usually lasts between 3 to 6 hours. That descent of the fetus is progressive. Dilation occurs about 1.2 centimeters per hour in moms who've never had a baby, and 1.5 centimeters per hour in moms who have had multiple. Definitely may see that pink or bright red bloody show. Those contractions are more regular. They are progressing to strong every 3 to 5 minutes, lasting 40 to 70 seconds. That backache will increase as that fetus descends. The uterus will feel firm when it's palpated. Mom at this point may have decreased ability to cope and maintain control at the end. She is more apprehensive. And she may have difficulty following directions. So now we're in the stage of she hates her husband. She hates all living things. She does not want to talk. She does not want to look at people. She needs quiet. Okay. So then the second stage is when the cervix is dilated 10 centimeters to the birth of the baby. So this involves moving the fetus through the birth canal and out the body. So the pelvic phase is the presenting part is getting into position, and the perineal phase is characterized by the urge to push. Second stage commonly lasts up to 3 hours in a first labor and up to 2 hours in subsequent ones. Those cardinal movements of labor are occurring. She might have spontaneous pushing. There is something called directed pushing. So your book says that this should be abandoned due to poor outcomes. It's better to allow women to push at her own urge instead of the nurse watching the fetal heart rate monitor and seeing when that contraction starts. So as a HESI hint, it is important to know the normal findings for a patient in labor. So normal fetal heart rate in labor is 110 to 160. Normal maternal blood pressure is less than 140/90. Normal maternal pulse is less than 100. Normal maternal temperature is less than 100.4. Again, she can have a slight elevation in temperature, basically because of dehydration, the work of labor. Anything higher would indicate infection and should be reported immediately. The third stage of labor is when the placenta separates and is exposed. The signs that the placenta has separated from that uterus and is ready to deliver, that uterus will rise upward, the umbilical cord will lengthen, there will be a trickle of blood, the uterus will change its shape to globular. So that placenta will be delivered in two different ways. You may see the shiny gray side called the Schultz or shiny Schultz, or the maternal side, which is the side that is attached to the uterus. That's the red raw side. This is the dirty Duncan. It just is red, raw, it just looks bad. Your job is to make sure that there are no placental remnants that are left in the uterus. Don't be pulling on it. Don't be tugging on it. Let it come as it comes, because you're going to increase that risk of leaving placental remnants inside of her, which can lead to postpartum hemorrhage. A normal blood loss in a vaginal birth is 500 milliliters and up to 1,000 milliliters for a cesarean birth. If there is blood loss over 1,000 milliliters, it is considered severe. So that fundus should be firm and well contracted. It's typically located at the midline between the umbilicus and the symphysis pubis, but then it slowly rises to the level of that umbilicus during the first hour after birth. Is the following statement true or false? The true pelvis lies below the linea terminalis. The answer is true. It does lie below the linea terminalis. The false pelvis lies above the linea terminalis. True or false? Cephalic presentation refers to a fetus whose head enters the pelvic inlet first. This is true. That head, vertex position, cephalic presentation. True or false? The second stage of labor is the longest stage. False. It is the first stage. And that is all I have for you for chapter 13.